Bismillahirrahmanirrahim. We would like to start the PPS 19th regional seminar of Pakistan Physiological Society with recitation from Holy Quran.
ये इधर रेसिटेशन भाई यहाँ बिस्मिल्लाहिर्रहमानिर्रहीम लिखा ये
Bismillahirrahmanirrahim. In the name of Allah, the entirely merciful, the especially merciful.
قُلْ أَعُوذُ بِرَبِّ الْفَلَقِ.
Say, I seek refuge in the Lord of Daybreak.
مِن شَرِّ مَا خَلَقَ.
From the evil of that which He created.
وَمِن شَرِّ غَاسِقٍ إِذَا وَقَبَ.
And from the evil of darkness when it settles.
وَمِن شَرِّ النَّفَّاثَاتِ فِي الْعُقَدِ.
And from the evil of the blowers in knots.
وَمِن شَرِّ حَاسِدٍ إِذَا حَسَدَ.
And from the evil of an envier when he envies.
Can you hear me?
yes
Thank you. Now kindly rise for the national anthem.
there is no sound
Thank you. Now I would like to request President Pakistan Physiological Society, Professor Dr. Umar Ali Khan, who is also the Pro-Vice Chancellor of ISRA University, for the welcome address.
Assalamu alaikum wa rahmatullahi wa barakatuh. Inna alhamdulillah wa salatu wa salamu ala rasulullah. I am very much thankful to Professor Aslam, our great teacher. So this time he is here, alhamdulillah. Jazakallah khair, sir. And then we have got Professor Bharti Mehta from Department of Physiology, All India Institute of Medical Sciences, Jodhpur. He will be talking about pathophysiology of jaundice. Then we have got a presentation by Professor Dr. Rashid Mahmood. He is Professor at HOD Physiology at Rahman Medical College and also the Chief Organizer, Chairman Organizing Committee of 18th Physiology Conference, which will be held from 6th to 8th of October this year in Peshawar in his institute. He'll be talking about pathophysiology of GIT diseases. Then we have got from Sindh, Professor Dr. Salma Farooq Memon, who is Professor of Physiology and Director of Library and Module Coordinator of MBBS. She'll be talking about renal pathophysiology. I'm again very thankful for Professor Sadia Hassan. She has traveled to this place from Foundation Medical University, Rawalpindi. She is professor and HOD of physiology there. She'll be talking about the gut-brain axis, unraveling the roles of gut microbes in bidirectional communication. Our student, now mashallah, she's Professor Farzana Majid. She's here, she's Professor of Physiology at HBS Medical College. She'll be talking about pathophysiology of peptic ulcer. Then another, our student, Professor Sidra Ahmed, she'll be talking about pathophysiology of hepatitis from Rawalpindi Medical University. So I welcome you all and over to Dr. Manazati.
Thank you, sir. Now we would like to request our Honorable Chief Guest, Professor Major General Muhammad Aslam, ex-Vice Chancellor, University of Health Sciences, Lahore, and Professor of Physiology at Shifa Tamir-e Millat University, for the introductory note on pathophysiology.
Can you all hear me, please? Can you all hear me?
Yes, we can, sir.
Thank you.
Yes, we can.
We are hearing you. Thank you, Dr. Aslam.
Haji. Slides, please. Slide show कर दे इसको. A'udhu billahi minash shaitanir rajeem. Bismillahir Rahmanir Rahim. Next slide, please. Now, my talk is very simple and very, very basic. And it is that the title says it is introductory note. Introductory note on pathophysiology. Because we must know that what do we mean by the word pathophysiology? Now, because it has been in my experience that either we go too basics, that is, we become too divert towards more science, or we divert more towards clinical, that is symptomatology and the management, even in asking questions or even in grading or even in setting the papers. So what do we mean by the word pathophysiology? So then it came to my mind, we must have a basic knowledge of what is basic physiology. What do we mean by applied physiology? What do we mean by clinical physiology? And what do we mean by pathophysiology? So these are just the definitions as the thesis opens, and there are certain operational definitions. So it is an introductory note to today's webinar. Next slide, please. So basic physiology. Previous slide, please. Previous slide, please. Basic physiology. Slide बंद कर सकते हैं front पे. Physiology is the science of life or the study of functioning of living organisms. ये भी बात कर रहे हैं. The physiology is the science of life or the study of functioning of living organisms. So that means that physiology does not live only in human, it belongs to all living organisms. Whether plants, whether animals, whether reptile, whether insects, maybe any family on God's earth, जिसमें रूह फूंक दी गई है, that means the living organism, and that is what is going to be the theme of the 8th conference of Pakistan Physiological Society. Where there is life, there is physiology. So in all the living organisms. Now it aims to understand how molecules, cells, tissues, organs, and systems carry out the normal functions of life. So in all Ziru, in all living organism, to know the normal function of the molecules, cell, tissues, organ, and systems is the true meaning of basic physiology. Now, what is applied physiology? Next, please. Applied physiology, it is the study of biological systems and how they relate to health, performance, and disease. It is a study of biological system and how they relate to health, performance, and disease. It involves the application of knowledge of physiological properties to various settings, not only to disease. When we exercise, how do they relate with it? When the female conceives, how does it relate to it? When female lactates, how does it relate to it? When we are not in a good mood, how does it relate with it? When we are happy, how does it relate with it? When we eat food, how does it relate with it? When we are with empty stomach, how does it relate with it? Today, renal, when we hold urine, how the physiology is diverted toward that. So that would mean I repeat so that it gets imprinted in your neurons. It is the study of biological systems and how they relate to health, performance, and disease. It involves the application of knowledge of physiological properties to various settings of life, is applied physiology. Next, please. And what is clinical physiology? Like previous slide, please. Clinical physiology. Clinical physiology is branch of physiology that deals with function and dysfunction of human body in disease process. It uses specialist equipment and advanced technologies to perform diagnostic tests and therapeutic intervention on various organs and systems. So clinical physiology deals with the function and dysfunctions of human body in disease, and there are certain branches of clinical physiology. Next slide, please. These are the branches of clinical physiology. So, clinical physiologist could be an audiologist. He knows about physiology and has got doing audiometry. And could be a cardiophysiologist, you know it well, electrocardiophysiology, electroneurophysiology, like even electrorenophysiology, could be gastrointestinal physiology, could be like, so they are all cardiac physiologists. Like, and then is neurophysiologists. Aapne dekha, NCS, EEG, and many others evoked potential are measured by the neurophysiologists. Then there are respiratory physiologists. So it comes to a GP, general practitioner, then goes to a renal respiratory physiologist, and then he goes to a pulmonologist. So workup is done by the respiratory physiologist for the clinician, like to review it and to give the management. Similarly, reproductive physiologist. A female goes with amenorrhea. Now, what is the cause of amenorrhea? It is the job of reproductive physiologists. So when the cause is known by various tests and the knowledge, then she goes to a gynecologist for the management and the treatment. Similarly, neprophysiologist, as renal physiology is today, neprophysiologist or uroneprophysiologist. Like, so they see what dysfunction is there and what could be the problem based on those investigations, and then they go to a nephrologist or urologist for management review and management. And then it could be sports physiologists, like, and there could be different. For kabaddi, there must be a different sports physiologist. For football, various marathon runner, a different sports physiologist. For a 100-meter race, because one is for strength, the other one is for endurance, like physiologists. Similarly, there could be gastrophysiologists, like up to branches aa gayi hain. You know it well, neurogastroenterology. The cause is in the brain. Dr. Sadia Hassan ka bhi hai ki gut-brain axis. The cause is here, problem is here, but the expression or symptomatology is in the gut. Like abdominal migraine is a new entity. Now, so gastrointestinal physiologist, and then there is a sleep physiologist. People come with disordered sleep, they go to a physiologist, he does various with background of his knowledge, he investigates them and finds the cause for it, then he sends them to, say, a neurologist or any sleep expert, like, so that for the management and interventions, and many more. There could be numerous clinical physiologists. So I would suggest it is a high time for the physiologist to go for the specialty branches of physiology. If a physician could be cardiologist, pulmonologist, psychiatrist, psychologist, gastroenterologist, nephrologist, like, and pulmonologist, why can't a physiologist be a pulmonary physiologist, cardiovascular physiologist, and urophysiologist, or GI physiologist, and so on? But the question still remains unanswered. What do we mean by pathophysiology. Next slide, please. Pathophysiology. Pathophysiology is the study of how a disease, injury, or other condition affects a patient physically, mentally, sexually, and in social behavior. Because according to WHO, the definition of health is a physical, mental, sexual, and social health, and not measure absence of disease. Right? So pathophysiology is a study of how a disease, injury, or other condition affects a patient physically, mentally, sexually, and in social behavior. So to make it more elaborate, next slide, please. So concept of pathophysiology. Concept of pathophysiology. Now, pathophysiology is knowing or the knowledge of process by which physiology is transformed to pathology. Pathophysiology is to learn the process by which is transformed to disease. Pathophysiology is a process by which norm is translated into an abnorm. So knowing the process of disturbance of physiology to pathology is called as pathophysiology. How in the particular disease the physiology principles have been disturbed is pathophysiology. It is neither management, it is neither investigation. It is to learn the process of the disease process, not the disease itself, but development of the process of the disease is pathophysiology. So while setting the paper, while taking the viva voce examinations, please take care of it. Pathophysiology is the process by which the functions are disturbed to convert a man into pathology. तो ये ख्याल रखिएगा at a hairline between clinical physiology, either we stay back in basic physiology or we jump too much in clinical physiology, which is not the domain of at least in medical schools in Pakistan. Our domain is to stay up to level of pathophysiology. Next, please. Now, concept of pathophysiology as it is defined, it is an intersection of pathology and physiology. So that means disordered physiological processes that cause, result from, or associated with a disease or injury. So pathophysiology is intersection of pathology with physiology. It means disordered physiological processes that cause, result from, or associated with a disease or an injury. Next, please. Now, core of the concept. So these are the operational definitions, basically. Cores of the concept. The cause is etiology, or we can call it etiopathology. Sometimes this term is also used in the textbook. The cause, is etiology or etiopathology. The mechanism of development is called as pathogenesis. But there is a hairline difference between pathogenesis and pathophysiology. We may take it as one. The mechanism of development of the disease, pathogenesis. The alteration of structure and forms is called as morphology. So that is anatomy pathology. Are they called as applied anatomy? Sometimes they call it as clinical anatomy. The alteration of structure and forms is morphology. And then is, say, for example, how the cell shape and size and color changes in pernicious anemia or iron deficiency anemia or some other hematological disorder is the alteration of structure and form. So this is morphopathology. Like, and the process of functional alteration is pathophysiology. But pathophysiology and pathogenesis of the disease, they look like similar to each other. If not the same, they are similar to each other. So we must have a differentiation of etiology, pathogenesis, morphology, and pathophysiology. With this background and operational definitions, like let us come probably next slide, please. The last slide. Next, so to sum it up, what is now pathophysiology is also called as physiopathology. They are synonym to each other. Right? So physiopathology or pathophysiology is the study of physical and biological manifestations of a disease in correlation with the physiological disturbances and abnormalities. So pathophysiology or physiopathology is the study of physical and biological manifestations of the disease in correlation with the physiological disturbances and abnormalities. So today's talk is, next slide, please. This is the last slide. So today's talk is on, today's webinar is on pathophysiology of gastrointestinal, hepatobiliary, and renal disorders. So you know the limitations, basic clinical, basic applied clinical and pathophysiology by now. Now it will be directed towards gastrointestinal, hepatobiliary, and renal disease process. Not the disease itself, but the process of the disease development. With these words, I thank you very much indeed. Thank you all.
Thank you so much, sir. Our next presenter is Professor Dr. Bharti Mehta. She is the Professor of Physiology at All India Institute of Medical Sciences, Jodhpur, Rajasthan, India. You are connected?
Thank you so much. It is a pleasure being here. And when I was invited for this talk, I was quite excited because of one special reason that I want to mention here, share with you. I am a Sindhi.
Oh, good.
I am a Sindhi, and my forefathers have come from Sindh. My father from Ranipur, my mother from Dadu, my in-laws are from Jekmabad.
Oh,
And
great.
it is such a pleasure. I have grown up hearing these words, stories of Sindh from my grandparents and parents. And interestingly, till now, whenever there is some matchmaking or we are meeting some new Sindhi, we tend to mention which part of Sindh we come from. So
Right.
it is
I must add Ranipur, the biggest fort in Pakistan, and the oldest one is in Ranipur. And Ranipur has got the Great Wall of Pakistan.
Okay, that I didn't knew, but
Yes.
it is really a great pleasure for me talking to you. Thank you so
And-
much.
And Dr. Mehta, just to tell you that ISRA University is a university chartered in Sindh.
Okay.
So you feel at home.
So it is like kind of homecoming for me.
Yeah, sure. You're most welcome.
Thank you, thank you, thank you.
असांखे ॾाढी ख़ुशी थी आहे असां सिंध मां आहियूं असांखे ॾाढी ख़ुशी थी आहे त तव्हां असां सां कॉन्टेक्ट में आया आहियो
अरे मूंखे बि तमामु वधीक ख़ुशी थी धन्यवाद थैंक यू
वॾी महिरबानी
Thank you, thank you. So let me share my screen. Is it visible? Is my screen visible?
Yes, it is available. Is it
Go to
visible?
the slideshow, please.
Yes.
That's it.
Yeah.
Great.
Yes.
Thank
Yes.
you.
So thank you very much. And I am supposed to talk on pathophysiology of jaundice. for undergraduate students. So that is my that is what I was told, and I'll try to wind up in 15 minutes. I hope my time starts now. Thank you. So just a minute. I'm not able to cheat. Okay. So jaundice, we all know, is yellowish discoloration of skin because of increased amount of bilirubin in the blood, the normal amount of which is 0.2 to 0.8 milligram%. And this is most visible. Is it so? This is how a jaundiced person's hand look like, and this is the hand of a normal person. So the normal bilirubin levels are 0.2 to 0.8 milligram%. Bilirubin, we know, is the end product of hemoglobin metabolism, and its normal production in the body is only 250 to 400 milligrams daily. 80% of which comes from hemoglobin and 20% from other heme sources like myoglobin, catalase, cytochromes. So hemoglobin is present in the RBCs, and when the RBCs become senescent, aged, they complete their lifespan of 120 days, they are broken down to release hemoglobin. And this hemoglobin is a combination of heme plus globin, we know. Globin, which is the protein part, will go back into the amino acid pool, and the heme, 80% from hemoglobin and rest from other sources, will be acted upon by heme oxygenase, which releases iron, which is again reused. So the body conserves iron as well as globin, and porphyrin is then converted into bilirubin and biliverdin, and finally to bilirubin, which is a yellow pigment, which if increases will lead to jaundice. So this whole thing is happening in the reticuloendothelial system of the body. Reticuloendothelial system, the spleen, lymph nodes, macrophages, we know. So once this bilirubin is formed, we must first understand what is the normal physiology, how this bilirubin is excreted out of the body. And as Professor Umar Ali Khan rightly said, that to understand pathophysiology, we first need to know the process of physiology, and then we will find out where in the process there can be defects, and then they can exhibit as different types of jaundices. There are 3 types of jaundices, which we will just see. So bilirubin is bound to albumin, and this bilirubin, which is bound to albumin, is called unconjugated bilirubin, and it is water insoluble. And since it is bound to albumin, we all know that albumin, the plasma proteins, do not pass through the glomerular filtrate. So this kind of bilirubin does not enter in, it cannot be passed through urine. So it is not present in the urine. So concept number 1, students, unconjugated bilirubin cannot be found in urine. Now, when this unconjugated bilirubin, which is bound to albumin, enters hepatocytes. So hepatocytes in the liver, there is a protein which is called ligendin, which will take the bilirubin, and albumin will remain outside in the blood. So once the bilirubin enters into the hepatocytes, it will be acted upon by the enzyme uridine diphosphate glucuronide transferase, UDP glucuronide transferase, and it will be converted into bilirubin glucuronide. Now, this bilirubin glucuronide is called conjugated bilirubin. This is water soluble, and this can be found in urine. This can pass through urine because it is water soluble and it is not attached to albumin. So unconjugated bilirubin cannot be found in urine. Conjugated bilirubin can be found in urine, concept number 2. Now, when this bilirubin glucuronide is formed, it enters in the intestine through the bile canaliculi. And in the intestine, it will be acted upon by the intestinal bacteria to form urobilinogen. 90% of the urobilinogen will be excreted through the feces. And it is because of this urobilinogen, there is a characteristic color to the feces. So whenever there is more urobilinogen formed, more color, and if less urobilinogen is formed, less color to the feces. This urobilinogen, 90% is excreted out through the feces, but 10%, and out of this 10%, some will enter into the enterohepatic circulation, again going to bile canaliculi and recirculating through the intestine, and rest will be excreted in the urine. So whenever the urobilinogen increases, there will be increased urobilinogen in the feces as well as in the urine. Concept number 3. So up till this, this is taking place in blood. Up till this level, this process is taking place in the liver, and rest of it is taking place in the intestine. So this is the process of bilirubin metabolism in the body, and any defect at any of these levels will lead to increased level of bilirubin in the blood, and that will lead to jaundice. Now, let us understand how many types of jaundices are there. So the pathology can be anywhere in this process. And depending upon where the defect is, there are 3 types of jaundices, commonly known as prehepatic, if there is something happening here in the blood. It can be hepatic when the defect lies in the hepatocytes or in the liver, and it can be post-hepatic when there is some obstruction of the bile canaliculi, and whatever is formed in the liver, the conjugated bilirubin, cannot be released into the intestine. So now let us talk about this one by one. When can this increase? When can the unconjugated bilirubin increase? Now, when can the bilirubin increase? Bilirubin, we know, is produced from the breakdown of RBCs. So whenever there is excessive hemolysis, maybe because of abnormal shape of the RBCs in spherical in hereditary spherocytosis, maybe because of glucose 6-phosphate deficiency, maybe because of any other reason, hyper active spleen, or even in the fetus, whenever the fetus is born, whenever a newborn is a baby is born, the fetus has got a very high level of RBCs, and when a baby is born, these RBCs will break down, therefore really making a lot of bilirubin, and that is why more of bilirubin will be formed. So the cause of prehepatic jaundice will be hemolysis. And this bilirubin, if excess of bilirubin will be formed, excess of it will be entering the hepatocytes, excess of bilirubin glucuronide will be formed, excess of bilirubin glucuronide will be entering into the intestine, excess of urobilinogen will be formed, and excess of urobilinogen will be excreted in the kidney, in the feces and in the urine. That means if more of bilirubin will be formed, more of urobilinogen will be formed. Okay. If, of course, considering that the liver is normal. But now liver has also got a capacity. So the liver will try to conjugate as much bilirubin as it is presented to it. But since there is more hemolysis taking place, so it has got a limit. After some time, rest of the bilirubin will remain in the blood, and that bilirubin will be unconjugated bilirubin. And we know that unconjugated bilirubin cannot pass through the urine. So what are the features of this kind of jaundice, prehepatic jaundice? The main reason will be hemolysis. And in this case, the urobilinogen will be increased. This will also increase. Conjugation will increase. Urobilinogen will increase. The rise in and there will be increased urobilinogen in the feces as well as in the urine. And mainly the rise will be of unconjugated bilirubin, because that more and more hemolysis is taking place, and it is exceeding the capacity of the hepatocytes to conjugate it. So this unconjugated bilirubin will rise, and therefore bilirubin will not be present in the urine, and therefore this kind of jaundice is called acholiuric jaundice or acholiuric urine. That means bilirubin will be absent, but urobilinogen will be in excess. So this is hemolytic jaundice or prehepatic jaundice. Now coming to the next type of jaundice, which is the defect, when the defect lies in the hepatocytes or in the liver itself, like in hepatitis. So in this case, whenever, or cirrhosis. So in all these cases, in cirrhosis, you always get jaundice. So in hepatitis, in this, what is happening? The bilirubin which is formed or presented to the liver is normal, but the defect is there, and bilirubin is not able to conjugate whatever bilirubin, the normal amount of bilirubin also. And in later stages of hepatic jaundice, there will be some element of obstruction to the bile canaliculi as well. Therefore, the bilirubin that rises in this kind of jaundice will be both unconjugated as well as conjugated. Unconjugated because it is not able to conjugate whatever is being presented to it, even the normal amounts, and conjugated because whatever is being conjugated in the later stages, it is not emptied, it is not being emptied into the intestine. So the defect here will be the liver abnormalities. Here the conjugation is less than normal. Here it was more than normal in the prehepatic jaundice. In the hepatic jaundice, the conjugation is less than normal. The urobilinogen will be decreased in amount. The type of bilirubin that increases will be both unconjugated and later conjugated. And bilirubin may be present in the later stages in urine because the conjugated bilirubin will also increase. Now coming to the third type, suppose there is some obstruction in the bile canaliculi. Normal amount of bilirubin is formed in the body. Normal is being presented. The liver is conjugating whatever is given to it, but it is not able to empty the conjugated bilirubin into the intestine. So because of the back pressure, this conjugated bilirubin will go into the blood. So, and since no bilirubin is entering the intestine, the urobilinogen will be absent. So no urobilinogen in the feces, and therefore no color in the feces, no urobilinogen in the kidneys or in the urine. So what will be this? The defect will be obstruction in the bile ducts. The conjugation is normal. Urobilinogen will be absent, so there will be clay-colored stools. Conjugated bilirubin will increase, and remember concept number 2, conjugated bilirubin, if increases, it is water soluble and it can be found in the urine. So this will form a choliuric urine. That means bilirubin will be found in urine, and this imparts a deep yellow color to the urine. The normal color of the urine is because of urobilinogen, but deep yellow color may occur in obstructive jaundice, and that will be because of bilirubin present in it. So these are the 3 types of jaundice which can occur in whenever there is a defect, depending upon at which part of the process lies the defect. And this is the comparative one, the same thing which I have just told. The prehepatic is hemolytic, increased production of bilirubin. The conjugation here will be more than normal. The main type of bilirubin that increases is unconjugated, and since it is water insoluble. It cannot pass the glomeruli because it is bound to albumin. So there will be no urinary bilirubin present, but excessive amount of urobilinogen will be present in feces and urine. The hepatic jaundice is because of the hepatic damage and hepatitis. Conjugation here is impaired because even the normal amounts of bilirubin presented to it is not conjugated. The type of bilirubin rises is conjugated and later unconjugated, mainly later conjugated because of the element of addition of obstruction. The urine will be plus yellow because it will be in later cases because conjugated bilirubin will increase, so that can pass through the urine, and the urobilinogen and fecal and urinary urobilinogen will be less because less is being unconjugated. And in the obstructive jaundice, the pathology is the obstruction to the canaliculi. Conjugation here is normal. The type of bilirubin rises is conjugated bilirubin, which can pass through the urine, imparting a deep yellow color to urine. And the urobilinogen will be absent in the urine as well as stool, imparting the typical clay-colored stools of post-hepatic or obstructive jaundice. So this is all. So revision. There is an increase. Explain why there is an increase in both unconjugated and conjugated bilirubin in hepatic jaundice. In the earlier stages, it is unconjugated because the liver is not able to conjugate whatever is presented to it. And in later stages, conjugated also rises because liver has got will develop some obstructive element and will not be able to empty the conjugated bilirubin to the intestine. Clay-colored stools are seen in obstructive jaundice because conjugated bilirubin is not emptied into the intestine, and therefore urobilinogen is not formed and it is not excreted in the feces. So no color to the stools, and this will be clay-colored stools. And third, physiological jaundice is acholuric. Physiological jaundice is the neonatal jaundice or the jaundice which happens when the newborn baby is born. Excessive amount of RBCs which were present in the fetal life are now broken down, and more of bilirubin is formed. That will be unconjugated bilirubin, which cannot pass through the urine, and physiological jaundice is acholuric. Thank you so much.
Thank you.
Thank you.
Thank you so much, Dr. Mehta, for the wonderful presentation. Now I would like to call Professor Dr. Rashid Mahmood, a well-known physiologist. He is the professor and HUD of physiology at Rahman Medical College, Peshawar. Sir, you have 15 minutes total for your presentation.
Right. Right. Is it visible, my screen?
Yes, please.
Okay. Bismillah ar-Rahman ar-Rahim. The topic of my presentation is pathophysiology of GAT diseases. I start with recitation from Holy Quran. Bismillah ar-Rahman ar-Rahim. Ara'aytal ladzi yukazzibu bid-din, fazalikal ladzi yad'u al-yatim wa la yahuddu ala ta'amil miskin. In the name of Allah, the beneficent, the merciful, do you see the one who denies the reckoning, who shuns the orphan, and does not encourage the feeding of the poor? So pathophysiology of GAT diseases, and it starts from the anatomy of the pathophysiology of the GAT diseases. GAT starts from mouth to anus, and any anatomical fault will result into the pathophysiology. And as per US data, 1 of every 9 persons has the digestive disease. Physiology of the pathophysiology of the GAT diseases. The function of GIT is to provide the body with a continual supply of water, electrolytes, vitamins, and nutrients, which require the following. That is movement of the food through the alimentary tract, secretion of the digestive juices and digestion of the food, absorption of water and nutrients, circulation of blood through GAT organs, control of all these functions by local nervous and hormonal systems. And any abnormal function in any of these will result into the pathophysiology of GAT diseases. The contents shall include disorders of swallowing and esophagus, disorders of stomach, disorders of small intestine, disorders of large intestine, and some general disorders, a topic of 15 hours that shall be covered in less than 15 minutes, inshallah. Basic physiological principles of the pathophysiology include either there may be increased physiological stimuli, or there may be altered physiological response, or there are some exogenous effects. Increased physiological stimuli include irritation, over-distension, over-excitability, and inflammation. The altered physiological responses may be increased or decreased motility, increased or decreased secretions, decreased digestion, and decreased absorption. The exogenous effects, they are many, and they include obstruction, bacteria, viruses, toxins, chemicals, drugs, nervous factors like psychogenic movements like motion sickness. Disorders of swallowing and the esophagus. The paralysis of the swallowing mechanism may be due to damage to the 5th, 9th, or 10th cranial nerves. It may be due to damage to the swallowing center or paralysis of the swallowing muscles. Achalasia. In achalasia, the lower esophageal sphincter fails to relax during swallowing, and it results into the megaesophagus. In the Barrett esophagus, the stratified squamous epithelium is replaced by the columnar epithelium, and it may result into esophageal adenocarcinoma. Disorders of the stomach guard the gastroesophageal reflux disease, where there is abnormal reflux of gastric contents, especially the acid, into the lower esophagus, causing inflammation and damage to the esophagus. The gastritis is the inflammation of the gastric mucosa, and the chronic gastritis can lead to the gastric atrophy, then decreased absorption of vitamin B12 and pernicious anemia. Peptic ulcer shall be discussed separately. It is excoriated area of the stomach or the small intestine, caused principally by the digestive action of gastric acid or juice or upper small intestine secretions. Causes include high acid and pepsin, irritation, poor blood supply, poor secretion of the mucus, infections with H. pylori, and some other bacteria. Basic mechanism is imbalance between the rate of gastric juice secretion and the degree of protection. Bariatric surgeries are performed for weight loss. They include gastric bypass and partial gastrectomy, and there are many types of bariatric surgeries. Disorders of the small intestine result in the abnormal digestion and or absorption. Pancreatic disorders will result into abnormal digestion. There may be pancreatic failure or pancreatitis and some other diseases like cystic fibrosis, annular pancreas, etc. The malabsorption, also commonly called sprue, may be tropical sprue or non-tropical sprue, which is also called celiac disease or gluten enteropathy. There are different pathogenesis mechanisms involved, and they are common in different parts of the world. Cause may be unknown, and there may be flattening of the villi or atrophy of the villi. So the pathophysiology of the malabsorption includes partial villus atrophy, subtotal or total villus atrophy, or flat mucosa. The effects of the malabsorption include the decreased absorption of macronutrients or the micronutrients. And the causes of the malabsorption, they include lymphatic obstruction, reduced small intestinal surface. It may be iatrogenic, tuberculosis, tuberculous lymphadenitis, allergic and eosinophilic gastroenteritis, shortcut syndrome, Crohn's disease, lymphoma, and celiac sprue, etc. So all these will result into the malabsorption. Lactose intolerance is common in children, maybe in adults, is due to the deficiency of the intestinal epithelial enzyme lactase. Disorders of the large intestine, they include appendicitis, the inflammation of the appendix, which is the acute emergency. Slow movement of feces through the large intestine results in constipation. Paralysis of defecation in persons with spinal cord injuries occurs if the injury is at corna medullaris or below the corna medullaris. It may result in the paralysis of the defecation reflex. If the injuries are above the corna medullaris, the patient will lose the voluntary control, but the defecation reflex, it will remain intact. Inflammatory bowel syndrome includes Crohn's disease and ulcerative colitis. There's increased intestinal permeability and alterations in the microbiota, and that is also a separate topic. Diarrhea is a loose, watery, and possibly more frequent bowel movements. It may be infective diarrhea, secretory diarrhea, inflammatory diarrhea, or psychogenic diarrhea. Different causes of diarrhea are there. Many general GIT disorders, the important one, they include the vomiting. There are two centers in the medulla which may result in the vomiting center and the chemoreceptor trigger zone. This trigger zone is stimulated by morphine, apomorphine, and many anti-cancer drugs. The vomiting is the result of a vomiting reflex, and it also includes some aspects of motion sickness, nausea, and anorexia. GIT obstruction, it may occur at any part of GIT, pylorus, duodenum, small large intestine, etc. And it may result into the vomitus, which may be of different composition depending upon the site of the obstruction. The obstruction may be due to cancer, ulcers, spasm, paralytic ileus, adhesions, etc. Gastrointestinal autonomic neuropathy, common in long-standing diabetes mellitus. The pathophysiology, the symptoms, the clinical features, they depend upon the area involved. The gut axis is a well-known fact which shall be discussed separately. The gases in the intestinal tract, they are called flatus. The flatus is normally produced in the human body, but abnormal amount or abnormal composition may bother the patient and will lead to the attention of the physician. Finally, the prevention of these GIT disorders, if you follow the sayings of our Prophet Muhammad, peace be upon him, which was the pre-physiology era for more than 1400 years ago, there are many sayings which say us how to eat, like eat from one side of the plate, use your right hand for eating and the left for cleaning. You may eat the dropped bolus, eat less, eat together, drink water gradually at intervals. Thank you very much.
Thank you so much, sir, for the wonderful presentation. Now I would like to request Dr. Salma Farooq Memon. Madam is Professor of Physiology and Director of Library, Test Module Coordinator of MBBS from Liaquat University of Medical Sciences, Jamshoro. It's not Karachi, it's Jamshoro. Sorry, madam. आवाज नहीं आ रही। मैडम आपका माइक म्यूट है, काइंडली चेक। आप अनम्यूट नहीं कर सकते मैडम को माइक प्रोफेसर सलमान
वो म्यूट हो गई तो ये फिर अनम्यूट हो जाएंगी।
अस्सलाम वालेकुम आवाज नहीं आ रही है
जी मैडम यू हैव ज्वाइंड प्रोफेसर सलमा यू हैव ज्वाइंड
मैडम आवाज आ रही है अभी?
जी अब आ रही है मैडम लेकिन स्क्रीन शेयर नहीं है
हाँ जी पुढे के छून के दिशे होता हाँ उभी आहे एयरपोर्ट अच्छा अच्छा चल ठीक है हाँ जी जज़ाकल्लाह सॉरी ड्यू टू द टेक्निकल इशू
मैडम स्क्रीन शेयर नहीं है आपकी
हाँ जी बस
यस मैडम स्लाइड शो पे कर दो
शो हो रही है अब मैम
जी जी बिल्कुल शो हो रही है स्लाइड शेयर पे अगर काइंडली कर दें
हाँ जी ठीक है थैंक यू जज़ाकल्लाह प्रोफेसर मुनीजा बिस्मिल्लाहिर्रहमानिर्रहीम respected present chair Professor Dr. Umar Ali Khan Saab and respected guests of honor and speakers and dear faculty and student Assalamu alaikum and I have very happy good morning. Sorry माजरत से कि ये थोड़ा टेक्निकल इशू हो गया जिसकी वजह से हो गई लेकिन hopefully I finish within 15 minutes my presentation. So today I'm presenting the renal, run down the pathophysiology of the actual kidney. So today I'm presenting one of the important system organ of our body, excretory system, especially network nephrons. So all of you know that the kidney basically having a tube which is called nephron, and these tubes are involved in the formation of urine. In the kidney, how many nephrons are there? 1 to 1.2 millions. So, and every nephron has a glomerulus, which is filtration unit. So here we are the concentrated one nephron. How glomerular is functioning to filtrate, and that are the factors alter the filtration through the glomerular structures. So let's first hear the afferent arterioles, which is breaking to the filtration unit. Now that really happens, afferent arterioles are break down to the multiple capillaries, and these are capillaries rejoin each other and make one efferent arterioles, which bringing the blood and break down the bunch of
Sorry to
capillaries.
interrupt you, madam,
And
please slide show कर दें. Slide show पे नहीं.
slide show नहीं हो रही है.
प्लीज स्लाइड आगे जाइए. वो समझ रही स्लाइड नजर ही नहीं आ रही. वो आगे जा नहीं रही.
मैडम आगे मूव भी नहीं हो रही आपकी स्लाइड्स.
अब शो हो रही है मैम?
तो हो रही है मैडम, मूव नहीं हो रही.
अब
मूव नहीं हो रही. अच्छा अच्छा, वो मैंने मूव अभी नहीं की. अभी वो मैंने खुद मूव नहीं की इसलिए कि अभी नेफ्रॉन ही है. So there are the many factors which alter the filtration through the glomerular structures. Let's see here the afferent arterioles, which is bringing to the filtration unit. And now that's really happen. Afferent arterioles are the breakdowns to multiple capillaries, and these are capillaries rejoin each and make the efferent arterioles, which is bringing the blood and break down the bunch of the capillaries. And these are the anastomosing channels of capillaries are called the glomerular top. This is the top. You show this is the top. So which is surrounded by or involved by a group of double layer cells, very specialized epithelial cells, and they're having some food process called there is a podocytes here, and there is a called visceral epithelial cells. So these are connected and other parietal epithelial cells, and then cells join together another type of cells which are made proximal convoluted tubules. So this loop of the capillaries and especially anastomosing are the called glomerular capillary stop. So we can say that the one type of visceral group, another type of the parietal cells structure is called glomerulus. So this is important for the kidney. The blood supply go to the afferent arterioles, to the efferent arterioles, not direct to the venules. But in regarding other systems, they goes from afferent arterioles to the directly venules. So here in other purple blue types of cells is known as very important cell, mesangial cells. They have got many lot of the connective tissue. So we can say that glomerulus is a group of anastomosing capillaries present in the kidney invested by a double layer of epithelium cells having Bowman capsule. This is a epithelium. And the anatomy of kidney, all of you know that this kidney shape organ located in the either side of the spine and just below the rib cage in the retroperitoneal spaces. And each kidney composed of outer renal cortex and inner renal medulla containing the functional unit are called the nephrons. So the renal artery supplies blood kidney as well as renal vein carry the filtered blood away from them. So the kidney responsible to filter all the waste products, and it's also a good transporter from the kidney, urine, bladder, storage, the elimination to the urethra. So formation, these are the basic 6 steps for the urine create. From glomerular start from, which is very important, filter small solute from the blood, and the second is reach to the proximal convoluted tubule, it reabsorbs iron and other nutrients, toxins, and filtrate pH, and then it's come to descending loop of the hand limb, And aqua points allow here water pass the filtered interstitial fluid, and the fourth one is the then ascending loop of Henle. Here is the reabsorption of the sodium and chlorides, and then goes to the distal tubules. Here is a selectively secretes and absorption different ions to maintain blood and electrolyte balance. And finally, collecting ducts, reabsorption of the solute here, water from the filtrates. So the homeostasis of the kidney, basically function of physiological function of the kidney is regulate the body fluids by the electrolytes balance and maintain the blood pressure, and from there the system is very important system, renin-angiotensin aldosterone system, and the production of the erythropoietin hormone, which makes responsible for the RBCs, and it's regulate very important system, uh, oxygen system, and it's regulate the level of the pH due to maintains their acid-base balance, and activation of vitamin D due to the calcium absorption in the intestine, and influence of the bone health, overall mineral homeostasis. Of course, removal of the drugs, toxins from the body, waste products. So the major etiology of the kidney disorders are very, but most moderate are the infection, autoimmune disease, diabetes, hypertension, and many more. Type 1, type 2 diabetes are the nephropathy, and these are damage to the glomerular and renal tubules and progressively kidney dysfunction. And hypertension, as we know that it may be lead to the reduced kidneys function because they damage the small blood vessels and filtering units of the kidney. Glomerular nephritis, it's a very infection of the kidney, and this infection is an acute glomerular nephritis usually caused by abnormal immune reaction which can damage the glomerular. And polycystic kidney disease, this is a genetic disorder in which glomerulus nephron fluid filled cysts form in the kidney, gradually enlarge, interfering with kidney function over time. And urinary tract obstruction due to any tumor, stone, any enlargement, or due to enlargement of the prostates. So glomerular nephritis, basically, this is a very important infection, having weight loss and the low grade fever, facial, peritoneal, and headache, BP increase. So this is a usually characterized by the abnormal immune reaction, which is cause damage to the glomeruli. In 95% cases of glomerulonephritis, streptococci infection involving in other parts of the body, like the tonsils and the infections. So the antibody develops against the streptococcal antigen within few weeks and react and form insoluble antigen antibody complexes which gets deposited in the glomerula and evoke an inflammatory reaction. The glomerula get blocked, and those which are not blocked, their permeability increase and allow to leak of the proteins and red cells from the glomerular capillaries into the glomerular filtrate. In severe cases, there is a renal shutdown, and this results in the acute renal failure. So this is the slightly difference between the acute and chronic kidney and diabetic kidney. There are many causes, and according to their diagnosis and different treatments according to their causes. So these are sign symptoms: high blood pressure, weakness, loss of appetite, and urination problems, clinic. Diagnostic of the kidney according to the best of the medical history, physical examination, so, and urinalysis, and routinely we should test 6 monthly. After the 6 months, we should be test for the urine analysis and blood test. And that regarding the abnormality, see we can see the protein, blood glucose, white blood cells, and blood serum test. If they are not normal, then we go for the further test, imagine studies, ultrasound and CT scan. So we can say that any abnormality like kidney stones, cysts, or any tumor infection or any other abnormality. And if these are the abnormal, then we go for the biopsy, and we can see examine the microscopic to identify the specific kidney conditions, and other tests like our urine output check and other many. So these are the different types of the kidney, And basically difference between the acute and the renal kidney, this is adopting health lifestyle. We can treat according to the cause. So this is the first cause which necessarily adopt a healthy lifestyle. We can change our the health with the healthy lifestyle, like eating balanced diet and stay hydrated and regular exercise maintained by the healthy weight, avoiding so many things like smoking, alcohol, and other things like gutkhા, pan, chalia, and other medication, unnecessary, avoid the medication, dialysis, according if kidney needs the dialysis, we should go for the dialysis, and then kidney transplant. In case of end stage kidney transplant may be considered as a patient suitable condition. So it is implanted into the patient or the body to replace the failed kidney, and some managing complications. Kidney disease can lead to various complications affected other organ and system in the body, and it's essential to manage these complications appropriate, such as anemia, bone disease, and so many diseases, cardiovascular disease. Of course, monitoring the follow-up. And finally, I say that the kidney is a filtered, kidney is filtered our body, interestingly, up to 50 times a day, and drink plenty of fluid. Nutrition is very important, like fruits, veggies, and eat healthy food and avoid the such a type of junk foods. And here now you should like to be one of the 100. And last, I want to say that many thanks for the Sir President who gave me this opportunity as a guest speaker, Professor Muniza, and I very apologize to for a technical issue little. So thank you so much.
Thank you so much, Professor Salma, for the beautiful presentation. Now I would like to request Professor Dr. Sadia Ehsan. She's Professor and Head of Department of Physiology at Fauji Foundation Medical University, Rawalpindi. Her topic is the gut-brain axis. Ji, Dr. Sadia.
Thank you very much, Dr. Minaza, for the
Madam ji,
opportunity.
share karo presentation. Yes. आप खत्म कर दें यहाँ से।
यस खत्म होना था।
स्टॉप शेयरिंग यहाँ लिखा हुआ था, उसे यस कर दो।
यस करें इसको।
अब मैडम की लगा दो।
डेस्कटॉप पे।
डेस्कटॉप पे चले जाओ। डेस्कटॉप पे चलो। किस नाम से मैडम?
Gut brain axis.
डेस्कटॉप पे जाओ बेटा। नहीं आता है यार, हम मैडम सलमा हो गया, मुझे स्टॉप शेयरिंग करें।
फ्लैश में दिया था आपको।
अभी से शेयर कर दो।
इसको स्लाइड शो पे कर दें।
ये माइक्रो ये वो करो शो।
Bismillahirrahmanirrahim. Thank you, Dr. Umar, for the opportunity. Thank you, Dr. Munazza, for the introduction. I'm going to be talking about gut-brain axis, which is an active area of research. And scientists are still uncovering how the gut microbes, they affect the gut-brain axis and how it is influencing human health. So while I was searching for literature, I had a few questions in my mind. Next, please. Next, Katish. So I had these questions that what is gut-brain axis? Are gut microbes important part of gut-brain axis? How are gut microbes and brain linked to each other? Can any imbalance in these microbes, like that is dysbiosis, affect human health and well-being? Can gut microbes be manipulated or altered? Can these bugs act as drugs? So I had these questions, so I looked up the literature and I thought of sharing what I found. So let's start. Next, please. So gut-brain axis, if you can see this picture, it's a bidirectional link. It's a two-way talk from brain to gut. So when I say I have some gut feelings, so that means gut has something got to do with my feelings also. So brain, you can see the two people, one is going down and the other is going up. So there's a two-way communication, and this is basically, they're influencing each other's function. This is gut-brain axis. And very central to this link is our gut microbiota. Next, please. Gut microbiota that we acquire at the time of delivery, and it becomes stabilized by the age of 2 to 3. It comprises of about more than 100 trillion microbes, and over 5,000 species have been identified, and it makes up about 2 to 6 pounds of our weight. And mostly predominant phyla are firmicutes and bacteroides. And the known roles have been in food digestion, particularly carbohydrates, in vitamin synthesis like vitamin K. It is involved in epithelial cell maturation, making up the mucosal barrier. It helps in protecting that. It helps in development and education of the host immune system. It matures that. And there's also protection from the invasive providing nutrition, providing vitamins, helping in digestion. So these were the known functions. Next, please. So for the last few years, the function that is now the scientists are unraveling is its role as silent partner in our physiological and overall psychological well-being. This is being studied, and many clinical trials are being done. Also, the experimental studies are being done in a germ-free environment in animals. So this is what the scientists are still working on. Next, please. So how are gut microbiota and brain linked? So brain and gut, they do have a link, but these microbiota, they're acting as mediators of this crosstalk, and they're allowing each other to influence each other's function. So these messages, they are traveling from the gut to the brain and back from brain to the gut in a network of neural, hormonal, and immune pathways. Next, please. So this is the gut-brain pathways. You can see on the right side, my right side, brain, and on the left side, the gut. So they are communicating through the autonomic nervous system, brain, gut is being affected. Also, whenever there is stress, there is stimulation of the hypothalamic pituitary adrenal axis that is also affecting the gut. And gut, in turn, is affecting the areas of brain, particularly those that are involved in emotion, in memory, in cognition. Those areas are particularly affected, and the pathways are immune pathways, the endocrine pathways, and neural pathways. Some of the metabolites that can enter the circulation, they can cross the blood-brain barrier if they're small enough, and then these affect these HPA axis, also the emotional areas, the limbic areas, the cognitive centers. So these areas are affected. Next, please. I'll go elaborate that a bit more. If you see that how the gut is affecting the brain. So I've given about 1, 2, 3, and 4. 4 mechanisms. Let's look at the first one in the red circle, the immune cells. If you can see the gut barrier and the gut microbiota in the lumen. By the way, the colon is heavily colonized with the gut microbiota. The whole of the gut is, but it's the colon that is predominantly colonized. So the immune cell, the gut-associated lymphoid tissue that is present in the GIT, it is influenced by these microbiota, and these microbiota are actually helping you maintain the good and the bad bacteria balance, and they are maintaining pro-inflammatory and anti-inflammatory cytokine balance. So these immune cells are, because of these microbiota, because of interaction with the microbiota, are producing cytokines. Next, please. Next. So these cytokines, interleukin 10, interleukin 22, nerve growth factor, all of these are influencing the hypothalamic pituitary adrenal axis. So if this balance is lost, the response of the animal to stress is seen that it is exaggerated response. So probably these microbiota are controlling and restraining or limiting that stress response. The next is the number 2, if you see the neuroactive molecules. So the gut microbiota are also influencing the release of neuroactive molecules, transmitters like serotonin, GABA, dopamine, norepinephrine, brain-derived neurotrophic factors. These are thought to be helpful in development of neurodevelopment, neuroprotection, the synaptic development, and also for the maturation of the microglia. So you see, they're all important in the brain functioning. So all of these are thought to be released from the enteroendocrine cells, which are in turn influenced by the microbiota. And also the GI hormones, which are involved in the eating behavior, that is also in the brain. So the brain centers are affected by that. Number 3, next please. Some direct metabolites of the gut microbiota, especially the short chain fatty acids, butyrates has been studied. This has shown to be neuroprotective. And these metabolites, they are small enough to cross the blood-brain barrier, and they can also affect these areas that I told you that are involved in the mood and behavior of the individual. So last but not the least, next please. Some studies, there's a study going on in University of Alabama. It hasn't been published yet, but they have found traces of E. coli in the brain tissue where there was a cognitive deficit. So it hasn't been published yet. I'll be a bit skeptical about it, but we have these at least 3 mechanisms that have been shown that microbiota can affect the immune cells, can help in the release of the neurotransmitters, serotonin. We know 80% of it is from the gut. So gut has got something to do with the mood. So, and then the metabolites. So these are thought to be affecting the brain. Next, please. Now, what is brain doing to the gut? So from brain to the gut, we know that we have autonomic nervous system, which is affecting the brain, and it is in turn fortifying the action of the enteric nervous system. And that is involved in enhancing the secretions in the motility, in the reflexes. This is affecting the gut function, and it is providing a conducive environment for the microbiota to grow and multiply. So this is how it is affecting. And number 2, next please. At the time of stress. So at the time of stress, we know that hypothalamic pituitary adrenal axis is stimulated. When that is stimulated, it causes release of cortisol. So that cortisol, even short burst of release of cortisol, has an influence on the gut microbiota mass and biomass and its number and its composition. It can affect that. And if the stress stays there, the permeability of the gut barrier is affected, because there's the balance of the good microbiota versus the bad microbiota is gone. So the permeability is affected. So this is how from brain to the gut through HPA axis and through the vagal and spinal reflexes, it is affecting the gut. Next, please. Next, please. So what is dysbiosis? Dysbiosis and human health and well-being, dysbiosis means there's an imbalance. So you have more bad microbes and less good ones. So then you face dysbiosis. And there are studies which we're not exactly sure that dysbiosis is leading to the mental health disorders, or mental health disorders are leading to dysbiosis. We don't know clearly which one came first, but many studies have shown association with these problems, the mental health problems, and even neurodegenerative disorders also. So there have been association that has been seen. Next, please. Since we know that the healthy gut-brain axis is involved in synapse formation, in neurodevelopment, microglia differentiation, cognition, learning, memory, mood, etc., because of all the transmitters. So what will happen if the gut-brain axis is not working? It's interrupted. Next, please. if it is disrupted, then there'll be diseases like the association. Mind it, it's the association that has been found. The multiple sclerosis, Alzheimer's, Parkinson's, even neuropsychiatric disorders and autism spectrum disorders have also been shown to be associated with this biosis. Next, please. So can we do something about our gut microbiota? Can we manipulate? Can we alter it? Yes, we can. We can use probiotics, quite popular. Probiotics are the bacteria, the live bacteria containing food, for example, yogurt, cheese, easily available. We can make it at home. Prebiotics are the food for the bacteria, green leafy vegetables, grains, cereals. Then having a diverse diet, not just relying on sweets and sugars. Antibiotics, unnecessary use of antibiotics can be avoided. Fetal microbiota transplantation is also being going on from healthy donors. And we can modify our lifestyle by having enough sleep and exercise. Next, please. So can we say that bugs can act as drugs? Maybe yes. Psychobiotic term has been coined by Crayon in 2013, where he said that the live bacteria or the metabolic products, they might help in preventing these diseases. Next, please. So they have been used in mental health disorders, neurodegenerative disorders, neurodevelopmental disorders, and others like insomnia. Yet, next, please. There's a word of caution. We have got mixed results because all the studies have been done on animals, a few clinical trials, and they have only shown association. So what do we need to do? We need properly designed clinical trials and evidence-based recommendations so that we can give them safely and to have an effective use. Because you can't just tell a parent of autistic child that you start using probiotics or prebiotics and this is the ideal treatment. We can't do that. So this is maybe used as an adjuvant treatment, not as a proper treatment option, first line of option. So that's about it. Thank you very much.
Thank you very much. Excellent talk.
Now I will request Professor Dr. Farzana Majid. She is Professor of Physiology at HPS Medical College, Islamabad.
बेटा बात सुनो क्या नाम एक माइक उठा के दे
He will present on pathophysiology of peptic ulcer.
Bismillahirrahmanirrahim. Assalamu alaikum. Next morning to you all. I'm very overwhelmed and thankful to President for giving me this opportunity. So I'll be presenting pathophysiology of peptic ulcer today. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatan min lisani yafqahu qawli. Let's start. Next. So I told my peptic ulcer to take a hike, but it just gave me a heartburn instead. So let's start. Next slide. Peptic ulcer disease. It's a localized...
I cannot see the slides. There's no slides show.
तुमने स्लाइड को किया ही नहीं शेयर नहीं किया स्लाइड Now can you see sir?
Yes, now it is there. Slide show में चले जाएं तो बेहतर होगा.
Done.
Thank you, sir.
Focus नहीं, please focus it. Yes, clear now. Thank you.
So peptic ulcer disease is a localized lesion of mucous membrane of the stomach. If it involves the stomach, it is gastric ulcer. When it involves the duodenum, it is called duodenal ulcer. So typically extending through the muscularis mucosa of the muscle layer of the GI. Next slide. So there are two types of, broadly speaking, there are two types of peptic ulcers, gastric ulcers and duodenal ulcers. They can be differentiated depending upon their time of origin, onset, time of onset, type of pain, and the causative agent that is causing that ulcer. So gastric ulcers, they have burning pain. that appears 1 to 2 hours after meals. It is present in the upper left abdomen. It is also radiated to back and it is relieved by food. It is shallow in pain, and it has gastric secretions, which are in this type of gastric ulcers. There is decrease in production of gastric secretions. Older men, working class, blood type A, and unstressed peoples are those who are very stressful personalities. They have gastric ulcers. So drugs which are involved in this type of gastric ulcers are aspirin, corticosteroids, NSAIDs, clozapine, chronic alcohol abuse, and chronic bursitis. While in case of duodenal ulcers, burning, cramping pain, which appears 2 to 4 hours post-meal beneath the xiphoid and back, relieved by antacids and it causes increased gastric acid secretion. All the young men having all social classes or blood type O and chronic illnesses are predisposed to duodenal ulcers. The diseases which are associated with duodenal ulcers, these are COPD, cirrhosis of liver, chronic pancreatitis, hyperparathyroidism, and chronic renal failure. Next slide. So certain features which are associated with this peptic ulcer include loss of appetite and weight loss, nausea, copious vomiting, bloating and abdominal fullness, chest pain, melena, gastric or duodenal perforation leading to acute peritonitis, extreme stabbing pain, abdominal pain, epigastric, strongly correlated to meal times. And out of these symptoms, some are more common and some are less common. So risk factors for these peptic ulcers, they include smoking. Those who smoke, they are on increased, next slide please. Those who smoke, they are on increased risk of peptic ulcers because they are more infected by H. pylori. Those who are drinkers of alcohol, this alcohol can irritate and erode the mucous lining of your stomach, and it increases the chances of having peptic ulcers. All those who are having a lot of stress and they are type A personality are more predisposed to having these ulcers. And those who are in the habit of eating junk foods, they are also predisposed. Next slide. Alone, these factors, they do not cause ulcers, but they can make ulcers worse and more difficult to heal. Next slide. So this slide gives a quick review of pathophysiology of these ulcers. Basically, there is imbalance between aggressive factors, for example, acid and pepsin, and all those defensive factors, for example, prostaglandins, mucus, and bicarbonate layer. However, nowadays it seems that H. pylori is the major cause of these ulcers. So aggressive factors include HCl and pepsin, which may destroy the gastric and duodenal mucosa, leading to gastric and duodenal ulcers. While defensive factors, these include mucus and bicarbonate secretions, which protect the mucosa. So there is sodium and bicarbonate layer, which is considered as a buffer so that it inhibits autodigestion of the stomach wall. Then prostaglandins, including prostaglandin E2 and I2, they protect mucosa by inhibiting acid secretion, increasing mucus and bicarb production, and also enhancing the mucosal blood flow. One of the main action or function of prostaglandins is to increase the turnover and regeneration of damaged cells, and these damaged cells are being damaged under the effect of all these aggressive factors. So there is this balance between the hostile factors and protective factors, which ultimately lead to peptic ulcer disease. Next slide. So H. pylori, which is the most common causative factor, which is causing one by one. So this is the most important factor which is causing which is involved in the etiology of these peptic ulcers. So 95% in duodenal and 80% of the gastric ulcers are attributed to H. pylori. Next. So this may predispose to the development of gastric carcinoma. That's why it is really important to treat these H. pylori infection because they lead to gastric carcinomas. So they colonize in the human stomach in acid medium and they spread via fecal-oral route. And the prevalence of H. pylori in adults appears to be inversely related to socioeconomic status. It is also thought, next slide, next. It is also thought that water is a reservoir for transmission of H. pylori. Next slide. So this figure shows complete pathophysiology caused by this H. pylori. These are in number one, the slide showing the inoculation or movement of these H. pylori towards the stomach. They are ultimately invading the mucus layers and reaching up to epithelial layer. Then they cause conversion of ammonia because they live in the acidic medium. So they release an enzyme called urease, which then converts ammonia, which produces ammonia, which make it hostile to live in that environment. Then they multiply and reproduce, and ultimately they cause mucosal damage by the direct action of urease enzyme as well as by inflammation, which ultimately leads to mucosal cell death. Next. So the host factors, the host tissues, they can be damaged directly by urease mediated generation of ammonia and indirectly by urease induced stimulation of inflammatory response, which includes recruitment of leukocytes and triggering the oxidative burst in neutrophils. Next slide. So second is the drugs which will lead to this damage or erosion of gastric mucosa leading to peptic ulcers. And the mechanism, these drugs include, mostly these are non-steroidal anti-inflammatory drugs as well as corticosteroids. And the mechanism by which they cause this gastropathy is number one, by disruption of phospholipid membrane or the lipid bilayer. Then they or the endothelium of the GI mucosa. Then they cause damage to tight junction proteins, then lead to uncoupled mitochondria, pronounced regenerative changes in the epithelium, which are foveolar hyperplasia and hyperchromic cell nuclei. There is decreased mucus formation, which is considered to be one of the protective mechanism. Then subnuclear vacuolated mucus cells. There is mild diffuse mononuclear infiltration, and then bundles of cells in lamina propria, leading to edema with ectatic blood vessels. Then there are certain hypersecretory states which will lead to or which predispose one to develop these ulcers. And one of this is Zollinger-Ellison syndrome, which is gastrin-inducing tumor. So when this gastric or gastrin-inducing tumor is present anywhere in the stomach, it causes production of more and more gastrin from the G cells. And this gastrin then acts on the parietal cells to increase in the production or release or synthesis of acid in the stomach. Now, this acid, which will act on the gastric mucosa, it will cause damage to the mucosa of the stomach, from superficial to the deep layers, depending upon this and the symptoms of the disease. They are associated with these penetration of this acid and damage and erosion of by this acid of the gastric mucosa. So the symptoms also vary from superficial to deep, and then it also reaches duodenum, and there is increase in duodenal acid load, which leads to gastric metaplasia. And there is H. pylori colonization, and ultimately there is ulceration, breakage of the mucosa, and finally it causes bleeding, which can lead to hematemesis or melena. So clinical features, next slide. So clinical features commonly to have no pain or other symptoms, but if there is pain, if it is burning or cramping pain, it is duodenal ulcer, or if it is burning or gaseous pain, it is due to gastric ulcers. Next slide. Complications attributed to these peptic ulcers, they may be hemorrhage, perforation, and gastric outlet syndrome. So initially, all these ulcers, they are treated conservatively, but later on, if the disease progresses and if the symptoms do not relieve with the medication, so surgery may be required at any time of the therapy. Next slide. So diagnostic studies, these include next endoscopic procedures, which will determine the degree of ulcer healing after treatment, as well as it will help in the diagnosis of the problem. Then tissue specimens can be obtained to identify the H. pylori and to rule out the gastric cancer. Next. So tests for H. pylori, these are non-invasive serum or whole blood antibody tests. Immunoglobulin G or IgG levels are checked. Then there is urea breath test and C14 breath test. There are invasive tests. Including biopsy of the stomach and rapid urease test. Next. Barium contrast studies widely used. Next. X-rays can be done. Next. And gastric analysis and lab analysis. Next. So treatment of this peptic ulcer disease includes hyposecretory drugs, which are mainly PPIs, mucosal cytoprotective agents, these are prostaglandin analogs, and neutralizing agents, which are inorganic basic salts. So this is time to recap. Next slide. Just give a minute to look at this slide. This is a quick review of all the aggressive factors and defending factors and all the causative factors which are leading to development of these ulcers. So here I thank you all because my time is over. Thank you for giving me chance. Thank you.
Thank you
Well
so
done.
much.
Excellent job. But you have missed one, thing, the hike in petrol. These are practical, isn't it?
Our last presenter is Dr. Sidra Hamid from Rawalpindi Medical University, Rawalpindi. Dr. Sidra, you have joined. Dr. Sidra, you have joined.
We cannot hear you, Dr. Sidra. Please, I think there is some distortion in your mic going on. Please. Something is wrong. Dr. Sidra, we cannot hear you, please. There is some sound coming. Is he?
Is that you उन्हीं की तरफ?
Something wrong with the mic?
Connectivity ठीक है यहाँ पे। नहीं डॉक्टर सिद्रा, नहीं डॉक्टर सिद्रा, आपकी वॉइस बिल्कुल नहीं आ रही। डॉक्टर सिद्रा आप रीज्वाइन करें, रीज्वाइन करें डॉक्टर सिद्रा। तुम्हें आवाज जाके नहीं निकल रही है।
उनको कनेक्शन ही प्रॉब्लम कर रहे हैं।
अच्छा, कोई कनेक्शन एरर है क्योंकि हमें रीज्वाइन
Dr. Sidra, we are unable to hear you, please. And also there is no sharing of any slide.
साहब को तजुर्बा होगा ना अपनी स्क्रीन ले आप ये उन्होंने शेयर की
कि उनका सेशन ही आउट
अच्छा इनका सेशन ही
हो गया। उन्होंने पहले से ज्वाइन किया हुआ है ना, उनका कोई जूम का सेशन ही 40 मिनट्स होगा ना।
40 मिनट्स बोल रहा हूँ वो तो हमारे जूम पे सेक्शन है ना, उसका तो हमारा तो अनलिमिटेड टाइम
उनका
नहीं बेटी उनका मेरे ख्याल में उनका नेट कनेक्ट नहीं हुआ हमारा, वो तो हमारे जूम पे कनेक्शन पे है ना, वो तो अनलिमिटेड टाइम इनवाइट तो हमने किया।
Sir, we are getting late. Can we skip this one?
Just a minute sir, please ask her.
जी डॉक्टर सिद्रा कनेक्ट हो गए? डॉक्टर सिद्रा ऐसा हो सकता है फिर आप नेक्स्ट टाइम प्रेजेंट कर लें टॉपिक से, क्योंकि अभी लेट। अच्छा फिर आप इसे शॉर्ट कर देंगे ना, क्योंकि टाइम हमारा टाइम शॉर्ट। चलें ठीक है, आप बोले आपकी आवाज हमें वहां से नहीं रिसीव हो रही। शॉर्ट कर दूंगी, मुझे प्रेजेंट कर दूंगी
रिकॉर्डिंग गई
हम YouTube पे वो जो हमारा फिजियोलॉजी वाली साइट है उस पर डाल देंगे रिकॉर्डेड।
हाँ ये कहती क्या मसला क्या है?
कनेक्ट नहीं हो रहा वहाँ यूनिवर्सिटी से सर, हम मोबाइल पे करने की कोशिश कर रहे हैं कॉल।
मोबाइल से कैसे कनेक्ट होगा? इसी डिब्बे में रखते हैं, इसी डिब्बे में। I think we should call it off.
Yes,
we should call it off.
Dr. Sidra, you will share your presentation and we will put it on our YouTube channel. Now it's the time for question answer session. Any question answers from the speakers?
Yes. May I start? May I start with the question?
Dr. Sidra, we can see your presentation, but there is no sound.
डॉक्टर सिद्रा आपकी आवाज नहीं आ रही, प्रेजेंटेशन शेयर हुई है। मोबाइल पे देखें कोई, आप वेटिंग रूम में जाएं कैसे?
नहीं उसने एडमिट कर दिया मेरे सामने, एडमिटेड ऑल है। I think people are waiting now. You just call it.
So it's time for question answer session. Any question from the speakers?
Yes. May I start the question?
Yes, please. Yes.
Okay. My question is from Dr. Farzana Majid. Dr. Farzana Majid, you said that in the renal ulcer there are increased secretions and acid, and in the gastric ulcer there are decreased secretions and decreased acid. But why we then give the antacids in case of gastric ulcers if there are decreased secretions and we are giving the PPIs and other antacids? So can you please explain that?
So this is the thing, when I was trying to explore, I was unable to explore, but to me, maybe there are certain factors which ultimately suppress these secretions, but mainly we are saying that this is because of H. pylori infection. So maybe this is because they are converting these are causing neutralization of gastric acid secretions. by formation of ammonia. That's why when we check the secretions, they are low in case of gastric ulcers when compared with duodenal ulcers. This is what I assume, but I haven't found the answer.
ये ना दिखाओ, मतलब
And about the, you said the stress, the sympathetic stimulation. In the stress, mostly we have the sympathetic stimulation, and sympathetic stimulation generally in GIT decreases the secretions. Then why should stress and sympathetic stimulation should cause the ulcer and increase acid? Because generally they suppress the secretions. Parasympathetics, they increase the secretion. So why it is the other way around in case of peptic ulcer?
Sir, I am type A personality and I have more secretions in my stomach, although it's parasympathetic stimulation. That's why I assume that it causes increased production of acid when I am stressed. I exactly don't know the highlight.
यार उनकी शेयरिंग बंद कर दो, उनकी शेयरिंग बंद कर दो. Any other question, please? शेयरिंग बंद कर दो, अपनी बस अपना ये भी बंद कर दो, इसको भी ऑफ कर दो, सिर्फ हमारा कैमरा ऑन कर दो. Any other question, please? Right, then thank you very much, all of you. So now it's time for the shields and certificates. Okay, he's got an sorry.
Our next seminar will be on 13th of September, Wednesday. The theme is the pathophysiology of neuroendocrine disorders. Thank you.
Next webinar will be on 13th of September, Wednesday, 10 a.m. And topic is?
Pathophysiology of neuroendocrine disorders.
Right, thank you very much. So now time for shields and certificates.
So So first shield goes to Dr. Sadia Ehsan from Fuji Foundation.
बहुत बहुत शुक्रिया आपका जी. Well done. Thank you very much. And here is your e-certificate.
The second shield is for
छोटे छोटे डिब्बे पड़े हुए हैं, छोटे डिब्बे जो रखे हैं. सादिया देखा वो छोटे डिब्बे
Why not? Very nice.
Excellent.
Thank you very much. Just hold on. एक डिब्बा पूरा पड़ा यार गत्ते का. ये दिखाओ, ये दे दो. The small token also. ठीक है जी. Now
second shield goes to Dr. Farzana Majid.
इसमें से भी एक डिब्बा निकालो. Farzana Majid. Well done, Farzana. Excellent.
Well done.
And this is small gift for you.
Thank you, sir. So nice.
And your name and just come on. इनका नाम भी बता दीजिए. No shield or nothing, but just small gift.
It's Guledatma actually.
Professor, she's also professor of physiology at Fuji Foundation University.
And next one,
Dr. Madiha
Imran.
She's also from Fuji
telephone, asking someone to take my photograph.
Hira Ashraf. Third one is Hira Ashraf. She's also from Fuji Foundation Hospital.
पीटी का ओ लेवल्स का रिजल्ट आया और मैं बहुत सुन रही थी
Good time, mashallah. Madiha has got इससे मिठाई खानी है कि दफा में. So 1% Rashid Saab is ready for मिठाई. Madiha. So अपना Rashid Saab and all others, they will receive their shields inshallah ta'ala and the e-certificates today inshallah. Thank you very much. Jazakallah.
And sir, may I take the opportunity to request all to register for the conference and attend the conference and encourage the colleagues also to register for that.
7 लोगों ने
एक गुजारिश ये करनी थी राशिद साहब, आज इस खुशी के मौके पे आप थोड़ा टाइम एक्सटेंड कर दें तो हम
लोगों ने रजिस्टर किया।
आपसे कहता हूँ जल्दी करवाता हूँ। तो राशिद साहब अगर आप 30 अगस्त तक कर दें तो लोग ज्यादा रजिस्टर हो जाएंगे इंशाल्लाह। तो रिक्वेस्ट है आपसे, आज आपकी मीटिंग है तो उसमें कीजिएगा। नाउ देयर इज अ क्वेश्चन फ्रॉम प्रोफेसर सारिया एहसन टू यू फ्रॉम फौजी फाउंडेशन। लिसन टू हर।
अस्सलाम वालेकुम सर।
इधर आके
सर हमारे फौजी फाउंडेशन से 7 लोगों ने रजिस्टर किया, लेकिन अभी तक कोई कंफर्मेशन सिर्फ 3 लोगों की आई और वो 7
ये
तारीख
कब किया रजिस्टर आप लोगों ने?
7 अगस्त।
राइट, ओके। आज अभी हमारी 1:30 पे मीटिंग है और ये जो अमर अली साहब ने कहा डेट एक्सटेंशन का और आपका इशू हम उस पर रेज कर रहे हैं, इसमें रिस्ट्रिक्शन वगैरह सारी चीजें हैं, ठीक है ना? तो कभी कभी ऐसा होता है कि व्हेन यू सबमिट द फॉर्म इट इज नॉट सबमिटेड प्रॉपर्ली, तो रिकॉर्ड में नहीं आता। इफ यू सबमिटेड द फीस वो संभाल रखें रिसिप्ट, अदरवाइज भी वो कोई इशू नहीं, हम कोलेक्ट कर लेंगे, ठीक है ना? आई कैन नॉट लिसन यू, आपकी आवाज नहीं आ रही, आवाज नहीं आ रही। यस जी, अब आ रही है।
जी अगर हम अटेंड कर लें और कंफर्मेशन अभी तक नहीं मिली, कैन वी ऑल कम ओवर एंड विद आवर स्लिप्स?
Yeah, I guarantee you just come on.
just keep these receipts with you, ठीक है? और आज मीटिंग के बाद मैं सबको अपडेट कर दूंगा ग्रुप्स में। आर यू मेंबर ऑफ द पीपीएस ग्रुप?
जी जी
बस ठीक है, मैं सारी चीज उसमें अपडेट कर दूंगा। फिर किसी को इशू हो तो मुझे कांटेक्ट कर ले। मेरा कल से कुछ व्हाट्सएप में इशू है, आई होप कि आज कल में ठीक हो जाएगा। तो डोंट वरी, अगर आपने पेमेंट जमा कराई है तो वो फॉर्म दोबारा भी सबमिट किया जा सकता है, दैट इज नॉट एन इशू, वी शैल रिजॉल्व इट इजीली, डोंट वरी, ठीक है?
Good. Thank you very much, Raja Saab, and hope to see you all in the next seminar and then in the conference. Thank you very much. Jazakallah khair. Subhanakallahumma wa bihamdika wa nashhadu an la ilaha illa anta wa nastaghfiruka wa natubu ilayk.